Welcome. Today we're diving into a serious lung condition, septic pulmonary embolism, or SP. We'll explore what it is, what causes it, how it affects the body, and what can be done about it. This is crucial information for anyone interested in understanding complex respiratory illnesses. Septic pulmonary embolism occurs when infected clots, or thrombi, travel through the bloodstream and lodge in the pulmonary arteries, the vessels that carry blood to the lungs. These clots are typically seeded with bacteria, fungi, or other infectious agents. Common sources of these infected clots include intravenous drug use leading to right-sided endocarditis, infected intravenous catheters, septic thrombophlebitis, inflammation of a vein due to a blood clot with infection, and deep vein thrombosis complicated by infection. In rare cases, it can stem from infections in the pelvic region or even the skin. Essentially, any infection that can introduce microorganisms into the bloodstream and trigger clot formation can potentially lead to septic pulmonary embolism. The pathophysiology of septic pulmonary embolism is complex. First, the infected emboli physically obstruct the pulmonary arteries, leading to decreased blood flow to the affected lung tissue. This can cause pulmonary infarction, where lung tissue dies due to lack of oxygen. Second, the infection within the emboli triggers an inflammatory response, causing lung damage and potentially leading to abscess formation, cavitation, the formation of cavities within the lung, and emphysema, of pus in the pleural space. The reduced blood flow and inflammation impair gas exchange, resulting in hypoxemia or low blood oxygen levels. The body's attempt to compensate can lead to increased pulmonary artery pressure, potentially causing right heart strain. Septic pulmonary embolism is relatively rare, but its incidence has been increasing, likely due to the rise in intravenous drug use, the increased use of central venous catheters, and the growing population of immunocompromised individuals. It affects individuals of all ages but is more common in those with pre-existing risk factors such as intravenous drug use, indwelling catheters, and underlying infections. While precise epidemiological data is limited, studies indicate a significant mortality rate, highlighting the severity of this condition. The lack of comprehensive data also underscores the need for more research to better understand its prevalence and risk factors. The signs and symptoms of septic pulmonary embolism can vary, but often include a combination of respiratory and systemic manifestations. Patients typically present with fever, cough, chest pain, which may be pleuritic, meaning it worsens with breathing, and shortness of breath. Hemoptysis, or coughing up blood, can also occur. Systemic signs of infection, such as chills, rigors, and generalized weakness, are common. Auscultation of the lungs may reveal crackles or wheezing. In severe cases, patients may develop respiratory failure, characterized by severe hypoxemia and the need for mechanical ventilation. Because these symptoms can mimic other respiratory illnesses, a high index of suspicion is crucial for early diagnosis. Diagnosing septic pulmonary embolism requires a combination of clinical evaluation, imaging studies, and laboratory tests. Chest X-rays may reveal multiple nodular infiltrates, often with cavitation. Computed tomography, or CT, scans of the chest with contrast are the gold standard for diagnosis, as they can visualize the pulmonary emboli, identify lung abscesses or cavitation, and assess for emphysema. Blood cultures are essential to identify the causative organism. Additional laboratory tests, such as a complete blood count, inflammatory markers like C-reactive protein and procalcitonin, can help assess the severity of the infection and guide treatment. Differential diagnoses, such as bacterial pneumonia, lung abscess, and non-septic pulmonary embolism, must be carefully considered. Septic pulmonary embolism doesn't have official subtypes or classifications in the way that some other diseases do. However, it can be categorized based on the source of the infection, e.g., intravenous drug use related, catheter related, the causative organism, e.g., Staphylococcus aureus, Pseudomonas aeruginosa, and the presence or absence of complications such as lung abscesses or emphysema. Treatment and management of septic pulmonary embolism requires a multi-faceted approach. Prompt initiation of broad-spectrum intravenous antibiotics is crucial, with subsequent adjustments based on culture and sensitivity results. Anticoagulation therapy with medications like heparin or warfarin is often used to prevent further clot formation, although its role is controversial in the setting of infection and bleeding risk. Surgical intervention may be necessary in cases of emphysema or large lung abscesses. Supportive care, including oxygen therapy, mechanical ventilation if needed, and hemodynamic support, is essential. In some cases, percutaneous catheter-directed thrombolysis or surgical embolectomy may be considered to remove the infected clots, but these are typically reserved for severe cases. Preventing septic pulmonary embolism involves addressing the underlying risk factors. For individuals at risk for intravenous drug use, related infections, harm reduction strategies, such as safe injection practices and access to clean needles, are crucial. Strict adherence to sterile techniques during insertion and maintenance of central venous catheters can help prevent catheter-related infections. Prompt treatment of infections, particularly those involving the skin, soft tissues, or veins, can prevent the development of septic thrombophlebitis. For hospitalized patients, prophylactic anticoagulation may be considered in certain situations to reduce the risk of venous thromboembolism. The prognosis of septic pulmonary embolism depends on several factors, including the underlying health status of the patient, the causative organism, the extent of lung involvement, and the timeliness of diagnosis and treatment. Mortality rates can be significant, particularly in patients with severe sepsis or respiratory failure. Recent research has focused on identifying biomarkers to predict prognosis and response to treatment. Studies have also explored the use of novel antimicrobial agents and advanced imaging techniques to improve diagnostic accuracy and therapeutic outcomes. Continued research is needed to optimize management strategies and improve survival rates in patients with this challenging condition.